Dear colleagues, this is a presentation I prepared for the ESCA Congress 2022 in Paris, and it deals about the anatomic landmarks for tunnel placement in ACL reconstruction. Detailed knowledge of the ACL insertional anatomy is necessary for anatomic tunnel placement in ACL reconstruction. Several studies have described the femoral and tibial insertion site in detail, but as you can see in this example, there is not one true morphology of the ACL, and the size, shape and position of both the femoral and tibial insertions are still discussed controversial. Nevertheless, I think it is important to read all these anatomic studies in order to create an own picture in your mind on how your perfect ACL should look like. In-depth knowledge about the insertional anatomy is especially important since tunnel malposition is still a common problem. This is a study of the Mars group on 460 ACL revisions, and they found that a technical error was the single failure mode in 24%, and technical errors played a contributing role in 53%. And if you look on the table more closely, you can see that femoral tunnel malposition is by far the most common technical error, followed by tibial tunnel malposition. And even high volume ACL surgeons do not always achieve an anatomic position. In this cadaveric study, the variation between the intended and achieved femoral tunnel position was assessed in 221 experienced ACL surgeons, and as you can see here, there was a large variation, but more importantly, 40 surgeons achieved a position outside the native ACL footprint. This finding underlies the importance of detailed knowledge about the anatomic landmarks for tunnel placement. In the past, the clock phase was a common method to describe the position of the femoral tunnel. However, I think this method should be considered historical and not be used in modern ACL surgery anymore. And I really like the editorial commentary published by Mark Miller in the Arthroscopy Journal, who most likely shares my opinion. Also, the great Freddy Fu shared this opinion. He wrote that the clock phase reference is simple, but it's non-anatomic. The most important problem with the clock phase is that it is a two-dimensional template and it cannot represent the three-dimensional ACL attachment along the medial wall of the lateral femoral condyle. If you state that your tunnel is located at the 10 o'clock position, it can be anywhere on this line. Therefore, anatomic landmarks rather than the clock phase method should be used. Important landmarks for the femoral tunnel are the lateral intercondylar ridge, or the so-called residence ridge, the bifurcate ridge, the lowest point of the articular cartilage, the apex of the deep cartilage, and the posterior horn of the lateral meniscus. Before I will show you these landmarks in detail, it is important to clarify the anatomic terminology, which is usually based on the femur in full extension. The location of the tunnel is therefore described as proximal and distal, as well as anterior and posterior. However, in 90 degrees of flexion, this is somewhat confusing, and the terms high and low, as well as shallow and deep, are somewhat easier for surgeons. Nevertheless, both options are used in the literature. Another important issue to recognize is that you can only identify what you see. And as shown here on the left figure, if you use the anterolateral portal with a 30-degree arthroscope, it is really difficult to get a good impression of the entire medial wall of the lateral condyle. I highly recommend to regularly switch the scope into the anteromedial portal, which allows you a really good view on the native footprint as shown on the picture in the middle. Another option is to use a 70-degree arthroscope, but this is probably more uncommon for ACL reconstruction. Two important osseous landmarks of the femoral tunnel are the lateral intercondylar ridge and the lateral bifurcate ridge. The lateral intercondylar ridge, also referred to as the residence ridge, is a bony ridge in the medial wall of the lateral femoral condyle that runs from proximal to distal and is considered the anterior border of the ACL footprint. The lateral bifurcate ridge separates the footprint of the anteromedial and posterolateral bundle but this ridge is more inconsistent compared to the intercondylar ridge, which is found in almost every individual. The lateral intercondylar ridge has been identified in several studies and, as already mentioned, represents the anterior border of the ACL footprint. Therefore, the femoral tunnel should be placed posterior to this ridge. Here is an example where you can see both ridges very nicely. Here you can see the intercondylar ridge, and here you can see the bifurcate ridge. Other good landmarks are the lowest point of the articular cartilage and the deepest point on the lateral intercondylar notch. In this cadaveric study, the authors found that in 90 degrees of flexion, the center of the ACL can be located on the lateral notch at a height of 8.7 mm from the lowest point and anterior 11.5 mm from the deepest point. Similar measurements have been provided for the apex of the deep cartilage. Anatomically, the apex of the deep cartilage represents the deep and high corner of the cartilage on the medial side of the lateral femoral condyle, and the center of the ACL has been reported to be located 3 mm high and 12 mm shallow to the apex of the deep cartilage. An interesting landmark was reported by Weiler from Berlin. They observed that when the knee was brought to deep flexion, the posterior horn of the lateral meniscus was always located directly deep to the desired femoral insertion site. Accordingly, their recommendation is to use a 5.5 mm offset guide to bring the knee in deep flexion and place the tip of the offset guide on top of the posterior horn. In their study, this technique showed reproducible results. However, as you can see in this diagram, the center of the tunnels was mainly in an anteromedial bundle position. Since the femoral footprint is relatively large, the question remains at which position one should place the tunnel in single bundle reconstruction. An interesting concept is the differentiation between the so-called mid-substance or direct insertion and the fan-like extensions or indirect insertions. This concept was introduced by Mochizuki et al., who observed that a large part of the femoral footprint consisted of fibers which were adherent to the bone surface and did not change their orientation with knee flexion. For this reason, they termed these fibers fan-like extension. During knee flexion, a fold in the ACL femoral attachment was observed at the border between the mid-substance and the fan-like extension fibers. The attachment of the mid-substance fibers was significantly smaller than the attachment of the fan-like extension fibers. Here you can see the footprint of the so-called direct fibers and the footprint of the fan-like extensions or indirect fibers. The role of these different fibers has also been evaluated biomechanically, and it could be shown that 66 to 84% of the resistance to tibial anterior drawer arose from the ACL fibers at the central proximal area of the mid-substance fibers, that is area G and H, whereas the fan-like extension contributed very little. Similar results were observed in this study. The authors found that the fibers in the high area of the anteromedial bundle just next to the intercondylar ridge carried the majority of force during stability testing and were the most isometric region of the footprint. The authors therefore suggested that it may be advantageous to create a higher femoral tunnel at the lateral intercondylar ridge. So if you take a femur with the outlined mid-substance insertion and fan-like extensions, the most common recommendation to place the femoral tunnel would have been here in the classic mid-bundle position. But based on the studies I just showed to you, I tried to position my tunnel just here in a high anteromedial position. So let's move on to the tibial landmarks. Those are the medial and lateral tibial spine or intercondylar tubercle, the anterior intertubercle ridge, the medial intercondylar ridge, the retroeminence ridge, the anterior horn of the lateral meniscus, and the intermeniscal or transverse ligament. The bony landmarks have been described very nicely in this study using CT scans with 3D reconstruction. Posteriorly, ACL fibers inserted up to a ridge located between the medial and lateral intercondylar tubercle. This ridge was called the anterior intertubercle ridge, marked with B. Medially, ACL fibers inserted onto the ridge at the lateral border of the medial tibial condyle, the so-called medial intercondylar ridge, marked with D, and no distinct anterior or lateral bony border was observed. Since no distinct bony landmark exists, the intermeniscal or transverse ligament can be regarded as a soft tissue landmark. The authors of this study observed that the transverse ligament coincides with the anterior edge of the ACL tibial footprint. Here you can see a wire introduced at the level of the transverse ligament and another wire at the anterior border of the anterior ACL footprint, and both wires penetrate the tibial plateau at about the same position. Ferretti et al. Found the posterior edge of the intermeniscal ligament and the peak of the medial tibial spine to be the most reliable landmarks. They described the center of the ACL footprint to be located 9.1 mm behind the posterior edge of the intermeniscal ligament and 5.3 mm anterior from the peak of the medial tibial spine. Another bony ridge is the retroeminence ridge, also known as the over-the-back ridge or PCL notch. This ridge is located just anterior to the tibial PCL attachment, and the center of the ACL footprint is located 13 mm anterior to this ridge. A soft tissue landmark which is quite commonly used is the anterior horn of the lateral meniscus. Jackson and Gasser described that the AP center of the tibial tunnel is closely approximated by extending a line in continuation with the inner edge of the anterior horn of the lateral meniscus. However, in a cadaveric study it has been observed that the anterior root of the lateral meniscus had a variable relationship with the ACL tibial insertion, and several clinical studies could demonstrate that the use of the posterior border of the anterior horn of the lateral meniscus yields an inconsistent tunnel location. This landmark should therefore be used with care and only in combination with other landmarks. In summary, knowledge of landmarks is crucial for anatomic tunnel placement, and adequate visualization is necessary to identify important landmarks. The clock face reference should be considered historical. Important femoral landmarks are the lateral intercondylar and bifurcate ridge, the lowest point of the articular cartilage, the apex of the deep cartilage, and the posterior horn of the lateral meniscus. Tibial landmarks are the medial and lateral tibial spine, the anterior intertubercle ridge, the medial intercondylar ridge, the retroeminence ridge, and the transverse ligament, and the relation between the anterior horn of the lateral meniscus and the ACL footprint is variable. Thank you very much for your attention.